Hi, everyone. Thanks so much for joining us again. Hopefully today we're going to discuss laryngeal mask airways. And the reason for discussing it is twofold, basically. Number one, I've seen a lot of our young doctors be a bit scared of laryngeal mask airways because they're not really exposed to its use. And because of that, they often tend to uh, try difficult intubations and get poor results, or end up having to bag patients for very long periods of time with the mask, which can also be very tiring. So a laryngeal mask airway is an extremely important thing for us to know, and an extremely important thing for us to be able to use in emergency departments, because it's a wonderful tool. It really does help. So we're going to start and hopefully be able to talk about it. So the first thing is, when you are, and to those of you who are, joining us live, please, you can stop at any point and just ask me questions if you need to, as always, or be it on audio or whatever it may be, it's not a problem. So this is your typical laryngeal mask airway. Just a picture of a normal laryngeal mask airway. And as I said, the laryngeal mask airway does bridge the gap between intubation and face mask use. It's been around now for quite some time, so 1983. So that's now just over 40 years that it's been in use. And Dr. Brain, who actually invented it, was notorious for walking around with the LMA just walking around the hospital with it as he was designing it, because he's one of the people in the population who had designed without a gag reflex. So he was able to test it on himself quite a bit, and it's the main use of the LMA is to be able to get an airway without having to struggle for intubation, because it's extremely easy to get it in and it has a very high success rate. Now, before I continue, let me just say I'm well aware that the LMA looks like a certain piece of anatomy. I'm not going to say which one. I think it's quite obvious. And unfortunately, during the presentation, we'll have to use some phrases that may sound a bit like innuendo or double entendre, such as lubrication. You have to push it in, but be gentle. And, if at first you don't succeed, try again. But if you need to have a good laugh, now would be the time. But those of us who have been in the field for a long time, we've heard all the jokes about it. So it's a very well designed piece of equipment for what it does. But because of the way it looks, it sometimes does elicit laughter, even from those who are maybe using it for the first time and things like that. But in any case, that's just a little joke. But it always comes up whenever we discuss this, even amongst seniors. Sometimes it can be quite comical. So normally when you get a laryngeal mask airway, ideally, you should have it in the flattened position. Now, just to go back here, you'll see it's got an inflator. So that inflator normally hooks up just to your normal syringe. And the thing is, if you try and insert it while it's fully inflated, it will never go in. So generally, your first step is always to deflate it and then apply lubrication. I'm going to show you guys just now exactly how to insert it. And then once it's in place, that's when you're actually going to inflate it after that. Now, I just want to advise you guys that basically we've got, I just want to type it out here just so that you guys know. So the sizes of the LMA, they range from size 1 to size 5. All right. Size 1 is for, let's say, just less than 1 year, extremely small children. All right. So it's for less than a 1-year-old. You would use it. size 2 size 2 and 3 are for slightly bigger children. Now, it's a matter of just knowing exactly what age you are dealing with, but basically a size 2 would take you from just about a year to about 4 to 5 years old, and a size 3 would take you up to about, let's say, about a 12-year-old. So let's just say less than 12 years, you can use these two. A size 4 is used for, let's say, above 12 years, or or let's say a small female. That's where you would use it. So let's just put your 12 years, or a small female. And a size 5 is generally used for an adult male, or a large female. Okay, let's just say adult female and male. Okay, so the main thing with the laryngeal mask is not to be 100% sure on your sizing immediately. You may sometimes have to insert one, and you may hear a leak, and then you've got to insert another one. So don't stress yourself out too much about not getting it right, but you should at least know that there are these sizes. Now, as I said, because it bridges that gap between intubation and mask ventilation, it can save you a lot of trouble in the emergency department. Even if you've got a young child, let's say you're not used to intubating young children, you can ask for a size 1 or 2. In most hospitals, they'll be either in the emergency department, in the ICU, or in the theater, or in the pediatric department as well, should you have one. And, ask for 1 or 2 sizes, and then you attempt to use them so that you know how they're going to be used. So as I said, the first step is essentially just to deflate it, right? Just remove all the air. Then you do apply lubrication, and then you've got to, once it's fully inserted, you push it in as far as possible, but gently, and then you inflate it after that. So, sorry, let me just move this a little bit out of the way. So this is how you insert an LMA, all right? So a laryngeal mask airway, just call it an LMA for short now. Sorry, I just want to make sure of something. Okay, no, that's fine. All right. So here we have it in the deflated state, all right? So as you can see, it's inserted blindly into the hypopharynx, all right? So you don't need what you call it, a laryngoscope at all in order to insert the LMA. You just basically use your 2 fingers. Now, everybody has sometimes developed their different ways. You may notice your seniors or consultants using slightly different methods, but the method that's indicated here is the correct way, which is to place your 2 fingers just above the laryngeal mask itself and on the tube. And then using that, you guide it down into the hypopharynx. Now, if you once you've done that, you then, of course, remove your fingers and then inflate as well, right? So once you've inflated it, then it should form a nice tight seal around that larynx, and allow you to actually start providing breaths and providing ventilation. So there's a few things to understand to know whether it's been in or not. So the first thing is you shouldn't encounter resistance very high up. But once you encounter resistance as you're going down, then you should know not to push any further. The second thing is, don't forget to inflate it, especially the first 1 or 2 times when you use it. I've seen doctors completely forget to inflate it. They attach their bags, they start ventilating, and they wonder what's going on. So remember to inflate it. Now, how you know that it's in the correct place? There's 2 ways. Number 1, you won't hear any leaks. So you won't hear any whistling sounds, you won't hear any air escaping. And of course you'll get chest rise as you're starting to bag, because your bag will now be attached on the top over there. And the third way is that you'll actually feel an inflation around the area of your thyroid, or your hyoid cartilage, or thyroid cartilage. So even if you want to right now, just place your fingers just next to where your thyroid cartilage is. And basically, when your LMA is in the correct position, it bulges in that area. So that's how you know it's in the right place. Now, unfortunately, that's not something I can show you on a presentation, but when you have a chance to use an LMA, it's an extremely important thing to feel for, because what will happen is once you felt it once, you'll know immediately what happens. Okay. So the original LMA was developed exactly like this. And what they found with the original LMA was that, as good as it was, there was some, I wouldn't say issues, but there were some improvements that could have been made. So from the beginning, the LMA could have been used for ventilation. So let's say you've inserted your LMA, there's no chance of you getting a tube in for whatever reason. You can immediately put your patient on a ventilator and you can start ventilating them completely. But now they've got newer models. For example, the LMA ProSeal actually takes up to 30 centimeters of water, whereas the original LMA, this one that we see here, would only take about 20. So as you can imagine, it forms a much tighter seal around your airway over there, and provides much better ventilation as well. And I'm going to show you guys some of the newer ones that are available, so that if you come across them, then it's not a surprise when you see them. And then the only thing that you require is the LMA itself. It's good to keep an endotracheal tube, just in case you get your patient to a point where you feel, okay, I can try and intubate. You need lubricants, of course, to be able to get the LMA in. And of course, your monitors, your advanced airway management tools, they're talking about laryngoscopes. If you have a video laryngoscope, that's very good, So the insertion process just involves placing it into the hypopharynx, inflating the cuff, and confirming the correct placement via visible markers and patient response. So let's just put it here just so that we know exactly what we're talking about. So the 3 ways to confirm that it's in place. Number 1, sorry, there's no air leak. So you hear no leak whatsoever. All right. Number 2, you have good chest rise. Okay. Bilateral. All right. Good chest rise. And number 3, you can, you can physically feel the bulge of the LMA in the hypopharynx. So like I say, it's next to that thyroid cartilage that you can feel it. And that's how you know you're in the right area. Okay. Sorry, I think I spelled that wrong. Hypopharynx. Okay. I think these days we are a bit too dependent on autocorrect, so we forget about these things. So this is just the basics of how you insert an LMA and how you use it and things like that. So it's an extremely wonderful tool, and it's an extremely easy tool to use as well, because as you can imagine, this doesn't take you more than a minute. So instead of trying to intubate a patient for maybe 45 minutes to an hour, and everybody's trying and damaging teeth and things like that, if you're in an emergency situation, let's say, for example, you've got a patient with a massive abdominal wound, or who's bleeding out from an artery somewhere and who's also not breathing, you can't afford to waste time on intubation when there's a life-threatening injury somewhere else. And LMA works perfectly. Other areas where it may work is where you've got patients where it's so difficult to intubate that it's going to take too much of your time. So let's say, the patient's body habitus, they're very large in size, very short necks, a very anterior, pharynx, larynx. So I'm going to show you a few of the indications just now. So basically what it does is that it saves you time. And if you are not confident in intubation, it allows you to save the person's life until you can get somebody to intubate the patient, or alternatively, until you feel comfortable to try to intubate. So in other words, you may be in a situation where you want to stabilize the patient a bit more before you try and intubate. Now, as compared to a normal endotracheal tube, which I'm sure most of you would have seen, which only takes about 5 to 10 mils of air to fill it up. An LMA will take a minimum of, I'm talking about adult now, 20. And then for each of the other sizes from 1 to 4, it's indicated how much you should put. But it's the exact same process. Once you insert the air, you of course feel the little bulb. And once the bulb is nice and tight, that's how you know that you've inserted it correctly. So I hope you guys understand that part. So, it's extremely easy. It's already a pre-curved. So you just deflate, fingers just above the mask itself, a slide, of course, above the tongue. You're going to slide it above the tongue, as far down in the hypopharynx as you can. You remove your fingers, you feel for the bulge, you inflate it, and you start bagging. You look for chest straws, and you make sure there's no leaks as well. You can use an OP airway, an oropharyngeal airway at the same time to make sure the patient doesn't bite down. But generally, the LMA has a much thicker tube. It's much more difficult for a patient to bite down, but it's still a safer thing to do is to use an oropharyngeal airway. Okay, so we're just going to talk a little bit about the evolution and how some of them have actually, developed over the years. Because as good as the LMA was, one of the main criticisms of the LMA was that it still allowed, or there was the possibility of patients aspirating gastric fluids. So whereas an endotracheal tube doesn't allow for that. So, and of course, as I mentioned, patients biting on it. If you have a patient who's now going to need ventilation for an extra long period of time, there were problems with that as well. So, these are some of the newer ones that were developed. So this is the AQ masked laryngeal airway. So some of the it's a bit better in terms of the tubing that's used. So you can see it's much thicker. This one here, the AQ blocker, which, as you can see, has a little attachment that goes into the esophagus. So that what it does is create a barrier between the LMA and the esophagus, so that there's less chance of aspiration. Now, I must be honest, a well-placed LMA, there's almost no chance of aspiration. But nevertheless, because you haven't inserted anything into the larynx through those vocal cords, there's always that possibility. So that's one of the drawbacks of using an LMA. So these are some of the things that have been developed to try and counteract that, and this is an AQ SP, which I think is it's just a softer model that can be used for longer periods, and then there's the other ones that have been developed, for example, the LMA Classic, which you may hear about, which is the one that we use now majority of the time. The LMA Unique, which is a disposable one, which is also one that's available in most hospitals, from the your most rural hospitals up to your most advanced. Will keep one of these two, although you'll generally find your reusable models more in theater and your disposable ones in the wards and in the emergency departments and things like that. Your LMA Flexible is reinforced and is generally, it's better for those patients who are going to be ventilated through that. I'm going to show you this one just now, which is the LMA Fastrach. And the LMA Fastrach is actually used to help intubation. And then the ProSeal and Supreme have slight adjustments to make them fit over the larynx better. So you must understand that if you are working in the hospital, when you say an LMA, some people may ask you, which LMA do you want? And if you forget, just ask for a classic or a reusable or a disposable, and they will understand what you mean. If the second most commonly used one is the Fastrach, and then the rest of them generally tend to be used in ICUs or very specialized situations. So this is the thing for you to remember. Okay. I hope that makes sense so far. So this is a reinforced LMA that again is used more commonly, I think, in ventilated patients. And this is the Fastrach, which is actually used to assist in intubation, but allows you to ventilate. Now, I'm going to show you that one as well. So I hope you guys understand this. The reason why I want to show you this is because, it's a good thing to know, especially if you're on anesthetic rounds and ICU round, to know that an LMA is available and to know how to use the LMA and to know the indications for it. And of course, in the emergency department as well. It's something that we should use more often. Very often we tend to bag patients for too long, and we haven't created a good seal, and it's difficult on the person who's bagging. So if you suspect the patient may need slightly longer ventilation than you can provide with the mask, but it's too difficult to intubate, then remember to go for an LMA. Okay. And this is now the newer ones that they watch, which is a fiber optic LMA. Now, the fiber optic LMA is actually similar to the Fastrach, which is used for intubation. So this is one of the newer ones that's come out. So I'm going to show you how you actually use it for intubation. But this is just so that the person using it can actually view the vocal cords to actually intubate. So it's quite an amazing one. I watched a short video on it because it was the first in just doing the research for this presentation. It was the first time I'd come across it, and it was quite amazing, some of the ones that they've actually got. And yeah, apparently you can play Mario Kart on it as well. There's things that they are quite advanced. So this is something that everybody should know, which is how to use a Fastrach LMA. So I just want to go back just 2 steps, and I want you to note the difference in the curvature of the Fastrach LMA. All right. So as compared to a normal LMA, which just follows the normal contours of the oropharynx and the hypopharynx, here we see it takes a very dramatic 90-degree turn. And the reason for that is that it places it in a much better position to actually look at the larynx. So once you pass this in, it's almost similar to putting in a laryngoscope, if I can put it that way. It sort of sets everything up in the right position so that an endotracheal tube can actually be passed through to actually intubate the patient. So the way that you've got to think of a Fastrach LMA is 2 things. Number one, it's sort of a guide for you to be able to intubate your patient. But number 2, should that intubation fail, it in itself will function as an LMA. It will function as an airway. So this is the reason that the Fastrach is very commonly used in patients who have very difficult airways. So as you can see, it's a similar concept. It's a deflated LMA. They often have a handle or an area that the operator uses or the doctor uses just to be able to pass it through. It's a very reinforced tube because it tries to keep that shape as much as possible. It's the exact same principle in that it's pushed through until resistance is felt. It can't be pushed any further, and then it's inflated. Once it's inflated, there's a special endotracheal tube that's passed through. Now, the endotracheal tube that's used with a Fastrach LMA is not like your normal endotracheal tube. It's actually a lot more flexible. So a normal endotracheal tube won't be able to pass through here. So don't attempt it because of the 90-degree turn. So what happens is this is able to actually pass through because of the way that it's made. I think if you have a look at it here, you may be able to notice it here. I don't know if I can enlarge it enough, but it's actually, highly corrugated to allow it to bend at any angle. But I'm not sure if it's too apparent over there. Sorry, just get that there. All right. So we pass the endotracheal tube past that. And normally what will happen is once it passes through, it's exactly like a normal intubation. There's no resistance. The tube just passes through, and there's normally a level marker to indicate how many centimeters you are in. And once you get to that, then you know, okay, I'm actually in the trachea now. And once that is achieved, then what happens is that, again, the endotracheal tube is then inflated. The Fastrach is deflated, and the Fastrach is then removed carefully over the now placed endotracheal tube, which is also inflated as well. I hope that makes sense. You guys can give me like a little thumbs up in the chat, or you can shake your head, or whatever it may be, just to let me know if you guys understand this, because even though the normal LMA is such a simple procedure, the Fastrach LMA does require just a little bit of a few extra steps But essentially, you've got to think of it almost as like how we would insert a CVP, even though it's not exactly the same. But basically, what we are doing is we're using the LMA, the Fastrach LMA, as a guide. So I hope that makes sense. Okay, thanks. All right. So at least I know it makes sense. Okay. So if you think of it that way, then it's fine. And like I say, should you attempt to intubate and find it's not going through, you just can't get it in, then the Fastrach then functions as your airway after that. Okay. All right. So don't worry, not much more to go. I know it's a Saturday night and I know people have better things to do than listen to me prattle on. So indications for LMA. So it's used in cases where intubation fails or is difficult. So especially in patients with anteriorly situated larynxes, it's very common. Patients may be, for example, somebody's got neck trauma, we've confirmed it. We can't, we can't, manipulate the neck, or you yourself are not that, comfortable doing certain intubations, but the patient needs an airway. That's basically where an LMA comes in. So it's common in emergency settings, burn patients for short-term airway management, can be used in professional singers. I can't remember why I put this here. Okay, but anyway. But I assume professional singers are difficult to intubate. Okay, I have to go back to my notes and just think why I put that in, but I can't remember. So what are the contraindications and cautions? So there's not many, but it's not ideal for patients at high risk of regurg and aspiration. So those with confirmed gastroesophageal reflux disease, like for example, patients who are obese or are pregnant. But like I had said, if the mask is placed properly and you've inserted it as it's meant to be inserted, the risk of aspiration is not actually that high. And to be dead honest, aspiration pneumonia can be treated, a dead patient can't. So you'd rather get the airway instead of saying, oh no, this patient may aspirate and struggle with the bag for an hour and give them insufficient ventilation, and your patient, dies. So that's where you have to weigh up the pros and cons as with anything. So we do try to avoid it in severe respiratory diseases where there's airway obstruction below the larynx, or inability to assume the sniffing position. Although I must be honest, that's a relative contraindication, and I would say it's more of a caution. Airway obstruction below the larynx is often difficult. Even intubation is also difficult in that case. So these are the types of patients where, let's say you've got a space-occupying mass that's sitting below the larynx. In other words, if you put your LMA there, it's still not going to get enough air into the patient. These are patients who are better suited to surgical airways and things like that. You can use it in severe respiratory diseases. However, and a proper intubation is preferred, and like I say, it's limited in protection against aspiration. But as I had said, there are those that are now available that have some protection against it. And if you insert it correctly, you shouldn't have any issues actually with aspiration. I'll be honest, in all the times I've inserted it and made sure it was properly placed, even in patients where there have been gastric fluids coming up, I've never had a problem with aspiration. So if you place it correctly, you should be okay. And just as a safeguard, you can always pass a nasogastric tube as well. And it generally passes quite easily. Although sometimes we've had to deflate the LMA in order to get the nasogastric tube past, but not always. Sometimes if you use a smaller one, it just slips past and it can be okay. So what are the advantages? It's easier and quicker to insert. It literally takes 2 minutes. The thing that takes the longest is applying the lubrication and deflating and inflating. That's what takes the longest. And it's a high success rate in inexperienced hands. So that means even if you watch this presentation, you already know how to use it. Chances are you will do it correctly. It's very effective in difficult airway scenarios, like where they would normally use fiber optic intubation, blind intubation. it's much better to use an ET tube in the emergency department, sorry, an LMA in the emergency department than attempt some of these. And it's ideal for use in radiological settings, such as MRI, where you can't have metal components and certain things like that. Not that many ET tubes come with metal components, but it's one of the things that they did pick up. So it really is a good skill to learn. It's a good thing to practice. It's not a get out of jail free card. So it's not to say that, okay, I'm not going to learn how to intubate. I'm just going to learn how to put in LMAs and hopefully one day I'll learn to intubate. No, no, no. Intubation is superior and should be your go-to. But if you suspect you're going to struggle and you're going to hurt the patient, rather use an LMA in that case. Okay. All right. And that's the end. So just a little joke to finish it off. And I've seen now quite a few. I recently was watching a movie where they had the ET tube and the entire thing was just placed, like the tube was placed there. And I was seeing the ET tube's probably like right down into one of the lungs. But anyway, that's how Hollywood gets it wrong. So I'm not sure if you guys have any questions or anything like that. But yeah, Hollywood medicine is quite comical, that's for sure. But I hope you guys understand. I hope you guys understand how to use it. And I hope you guys will go back to your units and take out the LMA. Please, if it's sealed, don't unseal it. Some of them are quite expensive. And the nursing staff do get quite upset. But if you go into theater, they generally have the reusable ones, which most of your anesthetic consultants and seniors will be more than willing to let you have a look at. If you have a practice dummy in your hospital, it's a good thing to practice putting in an LMA. And honestly, once you've put it in once or twice, you'll never get it wrong after that. Fastrachs, it's a good skill to learn, especially if you're going into anesthetics, emergency medicine, ICU medicine. It's an extremely good skill to learn. So I just wanted to show it to you guys. If ever you are in a situation where you find that you are struggling to intubate, maybe you don't have the correct equipment, if you've seen this and you've seen how a Fastrach works, it's another tool in your arsenal, something that you can, for example, also ask them to lend you in theater, practice with it once or twice, and you'll see once you use it, intubation can actually be quite simple with the Fastrach, although it's not guaranteed. It's not that otherwise every intubation would be with the Fastrach. It's not guaranteed. It just increases your chances. So I hope you guys enjoyed that. And if there's any questions, now's the time. Alternatively, we can end the meeting. And, if there's, any questions, you guys can always ask me later. It's no problem on the group, on the YouTube via the comments, or, just direct message me, and we can always try and go through it from there. But I can see there's no questions coming up. So I hope you guys enjoy your Saturday night. And thank you so much for joining me. I really, really appreciate it. And thank you to all of you who joined as well. And I really appreciate you giving up your Saturday night for this. And I really, really appreciate that. So please enjoy the rest of your Saturday night, and hopefully we'll be doing another ECG on Monday. Okay, keep well and bye.